Hey everyone, welcome back to PediaTime. It's time to learn pediatrics. In this video, we're diving into Dandy-Walker syndrome, a crucial congenital brain malformation you need to know for your pediatric rotations and boards. Let's break this down into 5 essential points. First, what exactly is Dandy-Walker malformation? It's a congenital posterior fossa anomaly with 3 key features: hypoplasia or complete absence of the cerebellar vermis, cystic dilatation of the fourth ventricle, and enlarged posterior fossa with upward displacement of important structures like the torcula and tentorium. This happens during early embryonic development, specifically between weeks 4 and 12, when the roof of the fourth ventricle fails to develop properly. How does it present clinically? Most commonly, you'll see these babies in infancy with progressive macrocephaly. Their head circumference is crossing percentiles upward. They'll show classic signs of increased intracranial pressure, bulging fontanelle, projectile vomiting, and irritability. Developmental delays are common. If diagnosis is delayed, older children might present with ataxia, hypotonia, nystagmus, or cranial nerve palsies. Here's a critical number to remember. 70 to 90% develop hydrocephalus because of CSF outflow obstruction. Third point, Dandy-Walker rarely comes alone. About 20 to 25% of patients have corpus callosum agenesis. 20% have cardiac defects. You might see urogenital anomalies, polydactyly, occipital encephaloceles, or cortical heterotopias. It's also associated with chromosomal abnormalities like trisomy 13, 18, and 9p deletions, plus genetic syndromes including PHCE syndrome and Walker-Warburg syndrome. Always screen for associated anomalies. How do we diagnose it? Prenatally, ultrasound can detect it after 18 weeks, showing that characteristic posterior fossa cyst and cerebellar abnormality. Postnatally, MRI is your gold standard imaging. You're looking for that classic triad: vermian hypoplasia or agenesis, enlarged cystic fourth ventricle, and expanded posterior fossa. Important differential diagnoses include megacisterna magna, Blake's pouch cyst, and posterior fossa arachnoid cysts. MRI helps distinguish these. Finally, management and prognosis. Treatment is primarily about managing hydrocephalus, either with VP shunt placement or endoscopic third ventriculostomy with choroid plexus cauterization. These kids need multidisciplinary care. Prognosis is highly variable. Isolated Dandy-Walker with early intervention can have normal or near normal outcomes, but when severe associated anomalies are present, the prognosis is poorer. Long-term, 40 to 70% may have intellectual disability, 15 to 30% develop seizures, and motor deficits are common. Early intervention therapy is absolutely crucial. And that's Dandy-Walker syndrome in 5 points. Remember, cerebellar vermis hypoplasia, dilated fourth ventricle, enlarged posterior fossa, and always look for associated anomalies. If you found this helpful, please hit that subscribe button and turn on notifications so you never miss an episode. Share this with your study group preparing for pediatrics. Drop your questions in the comments below. Until next time, this is PediaTime, time to learn pediatrics.